first 6 weeks is, well, the first week, letting it heal, getting over the surgery. We don't do therapy usually the first week. Sometimes, if the surgeons are aggressive. The second week, we start passive, range of motion only modalities, hand exercises for pumping blood. And we do that for the 6 weeks that they're in the sling because it needs to move, but they can't move it
actively.
Right. There's no active at all. So after the 6 weeks, once they come out of the sling, that's when it all starts to hit the fan. That's when it starts to get fun. Yeah.
For both the PT and the patient.
Yeah, that's when because the protocol is going to tell you basically your parameters, right? For the first 6 weeks, it's very basic. You only have one or two things you can do. After that what we call phase 2, you have to be creative. Like you have to be able to come up with the right exercises to do that stay within the protocol, and that's what makes PT kind of an art. It's like, yeah, there's some science here. We need to follow these guidelines and do this, do that, but being able to build rapport with somebody early on is why you'll know your therapist real quick, because then after the 6 weeks and it's time to start really hurting them, and they're gonna have to trust you. You're gonna have to say, yes, you can do that, and they're like, no, I don't want to do that. I'm like, you're gonna do it.
And then that hurt you talk about, like, how do they know what's a good hurt pain and what's like, okay, yeah, that's not good?
Yeah, so what I tell people is you got to set a pain ceiling, like Willy Wonka. You get right up to it, you don't really touch it, and then you come down. If you get to that pain ceiling, you got to stop.
Okay.
We're done. And they sometimes don't know what that is, and we have to figure it out.
And that's a kind of just a process thing.
It's a process, right? And that's where the PT's judgment comes in. Like if I have a guy that's at week 7 and he's just out of the sling, and I have him doing like the pulleys, and he keeps doing this, right? I'm like, I'll put a 2 or 3 pound ankle weight on his shoulder and have him do it against the weight of the thing, and he's like, it just hurts too much. I'm like, okay, then we got to stop. You only do it to that point right there. And so it's a good way for them to see, like, okay, I know I can get to that point, and then I'm coming down. And they just go up to that point where it's like, okay, that's good, I can do this.
Yeah.
And then, nope. And then, so you physically find that ceiling when it comes to the
That's hard education, because some people are like, they just go crazy with it. You know what I mean? Yeah.
Well, and like I've seen some therapists that don't look at those compensations. Like, how do you know those compensations? Can you talk a little bit about what you should be looking at, whole body, not just movement?
So in that first 6 weeks when they're in the sling, one of the home exercises is pendulums, obviously, but the other one is
Pendulums. What is that?
Oh, so pendulums is where there's a right and a wrong way to do pendulums. It's you dangle your arm and you use your body weight and move your arm like it's got a weight on the end, like a pendulum. You don't lean over and stir the pot. It's not active. Okay. Right.
Yeah, after this we'll take a video of how the right way and wrong way to do
I'll pop up a video
pendulums.
while he's saying it.
Okay.
So one of the other home exercises everybody gets is doing scap pinches, like against the corner of a wall, or like a door jamb. Or sometimes I'll give them a foam roller, and they can lean up against the foam roller and do chin tucks and scap pinch, and they can do that in the sling, out of the sling. They can do that, and that's the main one, because that sets up, that's your building blocks for whenever they get out of the sling, and you start talking about compensations.
Right.
And being able to identify compensations in a patient is the number one thing that all therapists need to focus on.
I agree.
During post-op rehab, because you're preventing them from building bad habits.
Yeah.
I have a guy right now that had a labral tear, massive. It said the word massive in the MRI. It was a massive rotator cuff tear. He tore subscap, infraspinatus, and the supraspinatus. I mean, massive tear, biceps tenodesis, everything. Anyways, dude did not come to therapy for the first 6 weeks. He sat in his apartment and played NBA on the Xbox for 6 weeks because he didn't know he was supposed to come into therapy, and I can't get him out past this.
Yeah. So what happens during that time? Because PT is so important, it might be kind of boring the first 6 weeks, but why is it so important, and what are you trying to prevent?
So we're like what I was saying earlier with the scap pinches, you're preventing bad habits. So you're showing them how you're doing the passive right. You're showing them how the shoulder should be moving, and I see therapists do this sometimes where they just have the shoulder and they're just moving it, right? You have to block it and put it in the right position and then do the passive.
Right.
Unless you're trying to get scapular mobility, and then you can do scapular mobility modes, and you can do that.
Trying to get that ball to do that in that joint, right?
Exactly, the roll and the glide. You've got to make sure that you have the roll and the glide. And you set that up during the passive range of motion, and so then with the scap pinches, you're already getting them used to that idea of pulling their shoulders just back, right? And then when they're doing the pulleys and they're doing active range of motion, you're watching for those compensations, and that's the most important thing in the very beginning, like weeks 7, 8, and 9, is not letting them build compensations, because that's going to mess everything up. So this guy I was just talking about, he's going to do this every single time
because he doesn't have the motion to do it.
He doesn't have the motion to do it. So to get his arm up, which he needs to do, he's going to compensate because there's no motion there. So he's going to rewire the brain to use the deltoid to fire first.
I can do this.
Because the supraspinatus has got to fire first. That's the whole point, is it does that, and then the deltoid can take over, because the deltoid, the line of pull is like this, so it wants to go straight up, right? And especially after rotator cuff surgery, the rotator cuff's not doing anything. So as soon as you start moving it, the rotator cuff is going to be completely shut down, and all your motion is going to be coming from the big dumb muscles. Right.
Well, maybe one of the things you can ask is like, what compensations should I be watching for? Right. That'd be a good way to find out if your therapist knows what they're talking about.
Right.
Yeah.
That one.
Yeah, that's to your therapist.
Yeah, ask your therapist. And we've already told you one, right?
That's the big one.
Yeah, and then this kind of stuff.
Well, it's the whole.
Yeah.
So what I tell people is, once we start actively moving it, I have them stand in front of the mirror, and I'll put a line down the mirror, like just with a piece of tape or something, and have them line their nose and their forehead and their chin and their sternum and everything up with that line, and have them just do active flexion, no weights, right?
Right.
And I'm like, keep everything lined up on that strip of tape, and you'll see people, their first compensation, it's not this, it's this. They'll tilt their head over to that side, and that's where it all begins. So it's all about head positioning. So that's why we start.
Well, and you're in a sling, and you tend to go forward and tight upper trap, everything, scalenes.
And that's why we get them out of the sling at least once a week, and
to really get that good motion,
right,
in a good position.
Right.
All right. So here's the protocol. Just wanted to add this in here. You see, it has a little anatomy here. Talks about certain injuries, all that good stuff. Let's see, signs and symptoms, treatment, and rehab. And then you'll see all this that we went through. I mean, it's, how many pages is it? 20-something pages, I think. So enjoy. It's a big read. And if you have any questions, let us know. But you can definitely look through all this. This is just one general protocol. I mean, it matters who did your surgery, what protocol they wanted to use. Literally, I would call the physician or surgeon that did it. It's like, which protocol do you want? Please let me know. You see, there's pendulums, there's the scap pinches, all that good stuff. So pretty cool. And you wouldn't believe it, but this was for free on the interwebs. All you got to do is pull it up. And this here says Massachusetts General Hospital for Sports Physical Therapy. So I even helped with protocols like this whenever I was doing stuff. So you enjoy looking at all these, and like I said, if you have any questions, let us know. But this is just something to give you a good general idea of what you may be putting yourself through. All right, well, thank y'all. All right, and action.
Hey everybody, I'm going to show you a video on how to do a pendulum the right way. So a lot of people, they just dangle their arm down and then they move it. Right? That's not what you're supposed to do. You're supposed to let gravity do its job. You're not actively moving the shoulder at all, and you're using your body to rock back and forth to get that nice motion in the shoulder. It feels good.
Yep. And what I always did was I would tell them, you got the stirring the pot clockwise, counterclockwise, and then you also have, side to side, Danielson, and then you got paint the fence, all that stuff, just to get them moving. That's the whole point of that, and it's supposed to be all body movement, not using your shoulder muscles. Beautiful job, love.